Good morning everyone. Myself Dr. Vignesh from the Department of Prosthodontics, Crown and Bridge, Vinayaka Mission Sankaracharya Dental College, Salem. So today the topic that we are going to see is implant hybrid prosthesis. The contents that we are going to see is the introduction, the classification of different implant prosthetics, and then the surgical procedure for the all-on-4 or implant hybrid prosthesis, and then the lab procedures. So it is a crime to not mention Dr. Paringwa Brainmark, whose serendipity has led to the invention of a whole new venture of the implant prosthodontics. So the introduction, coming on to the definition of what is an implant. Implant is any object or material such as an alloplastic material or other tissue which is partially or completely grafted or placed inserted into the body for therapeutic, diagnostic, prosthetic or experimental purposes. So coming on to the classification of implant prosthesis, there are different classifications for implant prosthetics such as the Misch classification, the ABCD classification, and then the Bedrosian classification. We will be seeing one by one. So coming on to the Misch classification of implant prosthesis. So Misch classified different prostheses with the available bone. Okay. So the FP, it is classified into FP1, FP2, FP3, RP1 and RP2. So Misch classified, the Misch given a classification according to the availability of the residual ridge. So he classified it into FP1, FP2, FP3, RP4 and RP5. So what is FP1? FP1 is the prosthesis, fixed prosthesis 1. FP1 is the prosthesis which will be replacing only the lost tooth. So the resorption is very minimal. FP2 is the prosthesis will be replacing the tooth and a certain extent of gingival missing. Okay. So FP3 is a large amount of bone is lost. So the prosthesis will replace the crown part and then the gingival part also. So coming on to RP4 and RP5. RP4 and RP5 is if the interad space is more, then we will be giving RP4. 3 or 4 implants with the help of an bar is called as RP4, and RP5 is your implant overdenture. So what is the ideal crown height space for a fixed prosthesis? All these prostheses will have different indications for crown height space. So we will be seeing it. The ideal crown height space for a fixed restoration ranges from 8 to 12 millimeter. And then for a removable implant overdenture, it has to be 12 mm or more than that. So patients having more than 12 mm of crown height space, you cannot give a fixed prosthesis. So this is what it means. So this picture gives an example of how you are going to replace it. So on the right hand side, the patient is having very less or minimum bone loss. So you will be replacing the ideal prosthesis for replacement of this kind of patient is your ceramic metal or FP1 or FP2 prosthesis, and even FP3 can be given. So on the left hand side, you can see the bone resorption is more. So you will be giving an RP4 or RP5 prosthesis. To some extent you can give an FP3 prosthesis also. So these are the minimum vertical space required for different kind of prosthesis. Your fixed screw retained option is your FP1. FP1 requires a minimum of 4 to 5 millimeters of crown height space is enough. Okay. So the patients with very less bone resorption and very less crown height space, you can opt for FP1. So for a fixed screw retained option, abutment level prosthesis, your FP2 is 7.5 mm. So other overdentures and bar overdenture is 7 to 17 millimeter. You can give an overdenture. So this is what it means. So how will you find out the restorative space present? How will you find out? How will you come to a conclusion? So this is what is the composite defect method. So you will fabricate a denture for the patient, and then on the tooth space. On the tooth space here, you will be making a thermoplastic splint of a denture, and then once you fabricate a thermoplastic splint, you will be placing the splint onto the patient's mouth, and then if you don't see any gap between if you don't see any gap between the teeth and the ridge, you will be giving an FP1 or FP2 prosthesis. Or suppose if you see a gap between the ridge and the teeth, you can see clearly, right? You can see a gap between the teeth and the ridge. So in these cases, the gap between the teeth and the ridge is higher. So you will opt for FP3, RP4 or RP5 prosthesis. Okay. So now we coming on to Bedrosian classification. The first is Misch classification. Under Misch classification, there is FP1, FP2, FP3, RP4 and RP5. So coming on to Bedrosian classification. Bedrosian also classified according to the bone available, the treatment options that will be presented to the patient with the available bone. So he classified the maxillary arch into 3 regions, 3 zones. Okay. The first zone is premaxilla, as you can see here, right? The first one is premaxilla. The zone 1 is the premaxilla. Zone 2 is the premolar zone, and then zone 3 is the molar zone. So if the patient is having bone, sufficient bone in all the 3 zones, your normal implants, traditional parallel implants can be placed here. Understand? You all can see the diagram, right? So if the patient have bone only on the zone 1 and zone 2, you can give an all-on-4 implant. Your all-on-4 implants can be placed. And then if the patient has only bone in the zone 1, the premaxillar zone only, you can go for 2 straight implants, and then you can go for zygomatic or cortical implants. So these are the treatment options with the help of the available bone. Bedrosian gave the classification according to the bone available. So this is how this looks like. In the OPG, you will be doing a marking, okay, marking of the available bone, and then give a conclusion of the treatment plan. So this is how it looks like. In the first picture, bone is present in all the zones, all the 3 zones. So traditional implant is placed in the key implant positions. All are parallel implants. Okay. So in the second picture, the bone is present in only zone 1 and zone 2. So the treatment option is 2 straight implants and then 2 angulated implants. This is the all-on-4 concept. So third one is the bone is present in only zone 1. So traditional straight implants is placed in the zone 1, and then zygomatic implants are opted. So this is what the OPG marking does look like. So coming on to the ABCD classification. This is the third classification. This, according to ABCD classification, is divided into 4 components. The first component is age. According to the age of the patient, you have to define the treatment plan. So suppose if the patient is young edentulous patient and geriatric patient does not have the same treatment planning. Okay. So suppose the first picture is young edentulous patient. Patients who are less than 50 years of age are called as young edentulous patient. So the fourth picture is called as geriatric patient. Patient who are more than 75 years are called as geriatric patient. So you cannot give the same treatment plan for both the young edentulous and the geriatric patient. So what can you do? So there are certain specifications that young edentulous patients can be given a treatment option which involves a lot of surgical procedures and regenerative procedures. Okay. Whereas in geriatric patient, you cannot give a procedure which involves regenerative methods. Okay. So in order to reduce the bulk of the surgical treatment, you have to consider the treatment plan in mind. So the second one is bone support. Bone support is exactly the same as that of Bedrosian classification. It is also divided into zone 1, 2 and 3, and accordingly the treatment plan is considered. And then the third one is cosmetic display. Suppose the patient is having low lip line and then medium lip line and high lip line, you cannot give the same processes for all the 3 criteria. Okay. For a patient who has a low lip line, which is the gingiva is barely visible when the patient is speaking. So for the patient like that, you can give a hybrid prosthesis or a FP1 prosthesis also. The transition between the prosthesis and the patient's gingiva should be as invisible as possible. should be as invisible as possible. That is the implication of cosmetic display. Suppose if the patient has high lip line, so the gingiva of the patient is visible when he is speaking. So suppose for that patient you can give a FP3 prosthesis, hybrid denture, okay, so that you can raise the gingival transition even more apically, so that the transition is not visible when the patient is speaking. This is what the cosmetic display indicates. Okay. The fourth one is degree of resorption. So degree of resorption, there are lot of indications for different implant prosthesis, for selecting the implant prosthesis. So according to the degree of resorption, if the patient has a inter-arch distance of 10 to 12 mm, you can always go for a fixed option, which involves fixed FP1 prosthesis and FP2 prosthesis. In the removable option, it is contraindicated. Why it is contraindicated is there is less amount of inter-arch space. So the veneer material, that is your acrylic or the ceramic material, which has very less thickness. So there is always chance of chipping or failure of your prosthesis. Suppose the patient has 12 to 15 mm of inter-arch space. Under the fixed option, you can go for FP1, 2 and 3. Under the removable option, you can go for an overdenture with a locator. Okay, and then the bar supported overdenture is contraindicated here, because bar supported overdenture requires more inter-arch space. So the third criteria is 15 to 18 mm. So 15 to 18 mm, you can give under fixed option, you can give a hybrid prosthesis with different veneering material, and then under removable option, you can give a overdenture with ball abutments. Okay, always ball abutments require high vertical space than the locators. Okay, so if it is more than 18 mm, the fixed option is contraindicated, and then you always have to go for removable option. So this is what is the degree of resorption indicates. So you are clear with the ABCD classification, right? So what is the fuss all about? All the fuss about the implants placed angulated. So what is the concept behind it? So you can see two pictures, right? The right picture, there is a table with a straight leg. Okay, so see the cantilever, how much of length outside the leg the table can withstand. That is only minimum. So in the left hand side, can you all see the picture? It has an angulated leg. Okay, angulated leg space. So if the leg space is angulated, the cantilever or the prosthesis, imagine in this case it is the prosthesis. The amount of prosthesis that can be given outside of the implant is higher. Okay, you can extend the length. So that is what is the indication of this angulated implant or all-on-4 hybrid concept. So this is AP spread. AP spread is calculated, the length is calculated from the middle portion of the most mesial or most anterior implant to the distal portion of the most posterior implant. Okay, this length into 1.5 gives you the amount of cantilever that you can give on a prosthesis. So if you exceed this amount of AP spread, no, there is a lot of possibility of prosthesis failure. Okay, so this is what you have to keep in mind. We will see the surgical phase of all-on-4 placement. There are two concepts of placement. One is your conventional, and then the other one is guided surgery. Okay, the conventional is you are going to raise a flap and then place the implants. So under conventional surgery, what are the surgical steps that is involved? So this is how the patient look like. So the flap is elevated, and then this is called a Nobel guide. You are going to place this guide on the middle portion of the ridge. Okay, you are going to drill a portion and then place the guide, and then this guide will let you do the angulated implants freehand. Okay, look at this picture, the guide is placed in the most mesial position, and then the implants are placed according to the guide. Okay, so this is how the conventional surgery is done. What about guided surgery? Complete denture prosthesis is given. The patient is asked to take CBCT. Okay, through the CBCT, 3D printing of the surgical guide is done, and with the help of the 3D printing guide, you are going to place the implant without elevating any or raising any flap. Okay, so you all can see here, right? So these are the extension that will be drilled inside the patient's bone that will act as a stabilizing areas of the surgical guide. Okay, so this is how you are going to stabilize the guide and then place the implant through this implant stent holes. Understand? So this is the guided surgery procedure. So now coming on to different implant impression. So there are a lot of implant impression techniques that are followed. Okay, so you should be very clear about where are the different implant impression procedures are indicated. So we'll be seeing one by one. So implant impression is also further classified into conventional and then digital. Digital is you are going to use an intraoral scanner and then use the scan bodies to scan the implant impression and directly send the STL files to the lab, and they will fabricate you the prosthesis. Understand? So under conventional, you can do the implant impression at the time of the surgery and then give a temporary or provisional prosthesis, or you can wait for the healing of the implants and then take the final impression. Okay, based on the level of implant impression, it is called as implant level and abutment level, and based on the coping, what instrument or what material you are going to use, either transfer coping or the abutment directly, is classified into transfer, pickup and splinting. So these are the implant components which we will be dealing with while taking an implant impression. So this blue line indicates the bone level. These are the components that will be present above the bone level. Okay, this is the impression coping. Okay, you all have a clear idea. This is an open tray impression coping. The first one is the open tray impression coping. The second one is closed tray impression coping. Understand? So this is the analog. This blue line, as I told you, indicates the bone level. So the analog will stay below the bone level, underneath the bone level. Understand? So the temporary abutment also is used to give a provisional prosthesis, and then your final abutments which will be present above the bone level. I think this is clear. So now coming on to the first classification of implant impression, that is your implant level impression techniques. Okay, in this method there are two types of impression, that is, one is closed tray impression and then the other one is open tray impression technique. So under implant level impression technique, what you are going to use is a transfer coping. You are not going to take an impression with the help of an abutment. Okay, you are going to take the impression with the help of a transfer coping only. Understand? So this is what your patient's model look like. Understand? This is the simulation of the patient, and then when you take out the healing abutment, this is what the implant site look like. Okay, and then on top of it you are going to place a closed tray transfer coping. This is what a closed tray transfer coping looks like. Okay, and then you are going to try the tray and then inject the light body material, take the impression. So once you take the impression out, once the impression material is set and you take it out, this is how you are going to see the implant recording. Okay, and then you are going to unscrew the transfer coping. Closed tray transfer coping will be present inside the patient mouth. You are going to unscrew the closed tray transfer coping and then manually seat it inside the impression, and then on top of it you are going to place the implant analog. As I had told you, implant analog will be coming inside the patient's mouth or inside the model, and then you are going to place the gingival mask, inject the gingival mask at the level of the implant analog and then pour the impression. So your implant area does looks like this, and then beneath the implant area your implant analog will be inside the model. Understand? So I think you all have been clear about closed tray impression. Then now coming on to open tray impression technique. As the name suggests, you are going to make the tray and then seat the open tray transfer coping through and through the impression tray. Understand? So this is what the open tray impression coping will look like. Okay, once you place the tray, and then you have to check for the fit of the open tray transfer coping. These access holes should be coming outside of the impression tray. Understand? This is what is the main concept. So once you can see in the picture, right, the access holes are outside the impression tray. So now you are going to inject the material barring that access hole. You should not inject the material on the access holes. Understand? And then you try to seat and locate the impression tray. Once the material is set, inside the patient mouth only you are going to unscrew the transfer coping, open tray transfer coping, unscrew inside the patient mouth, and then once you take the impression out, the open tray transfer coping will come out along with the impression. So, this impression, open tray transfer coping impression is the most accurate impression technique, okay, because you are not going to take the transfer coping out and manually place it like your closed tray impression technique, okay. So, the procedures is all the same. Attach an implant analog, put the gingival mask, and then pour the model. So, now coming on to abutment level impressions. So, in this abutment level impressions, you are going to directly place the abutment and then take the impression, transfer the abutment, and or you have to use a snap, attachment snappy on top of the abutment, and then you have to transfer it to the lab. We will be seeing that. In the first procedures, you will be removing the healing abutment and then placing the final abutment onto the patient, okay. You have to close the access hole. There should not be any impression material inside the access hole. You have to close the access hole with the help of a modeling wax or putty, okay. And then you are going to inject the light body material and then take the impression. Once the impression is out, you are going to manually unscrew the abutment inside the patient's mouth, and then you are going to fit it inside the impression, okay, once the impression is made. So, the next one is, the first classification is direct abutment level. So, you are going to directly pick up the abutment. So, the second one is indirect method of abutment level impression technique. In this method, the same implant, the final abutment is placed inside the patient mouth, and then on top of it there is a snappy abutment, snappy coping, okay, snappy coping of the abutment which is attached on top of the final abutment, and then you inject the light body material on the snappy abutment, and then you take an impression, so that snappy coping will be picked up by the impression. So, once that snappy coping mimics the final abutment, so that you can place the implant analog directly on top of that snappy coping and then pour the model, okay. So, these are all the types of impression. Once you get to know all these types of impression only, you will be knowing, you will be clear with all the impressions, okay. So, now coming on to the implant hybrid processes. Now, I will be explaining about the surgical procedures and then the lab procedures also, okay. The surgical procedures are over, and then we will be seeing the implant impression technique and then the lab procedures workflow of the implant hybrid processes. So, the clinical workflow involves, the first appointment will be the implant after the surgical phase is done. The first appointment for prosthetic, you have to take an implant level impression. Implant level impression will be taken and then sent to the lab. The lab will fabricate a custom tray for you to take a final impression, and then on the second appointment you have to verify the jig, okay, verify the jig and make the bite registration for the patient. And then once you send the bite registration and the final impression, the lab will fabricate a master cast, and then they will give a metal framework, okay, and then they will do the wax teeth setting, and then you have to try in the third appointment you will be trying the wax trial, okay, and then send it to the lab. They will fabricate the processes, and then you have to deliver the final processes in your fourth appointment. So, I will be showing you the procedures one by one. So, this is how the multi-unit abutment looks like, okay. This is the multi-unit abutment that looks like. So, after the surgical phase, the patient will present you with the healing abutment. You have to remove the healing abutment and place the multi-unit abutment, okay. And then on top of the multi-unit abutment, you will be placing a open tray transfer coping, okay. This method being the multi-unit abutment open tray technique, you are going to place the open tray transfer coping, and then you have to make vent holes on the impression tray and then try the impression tray before taking the impression. You always have to try the impression tray whether the access holes are perfectly seating or not, okay. So, you have to try it. After injecting the light body material onto the open tray transfer coping, you are going to seat the impression tray. Once the impression is set, you are going to unscrew the open tray transfer coping, and then when you are taking it out, the open tray transfer coping will be picked up along with the impression. You have to put the gingival mask and then pour the impression, and once you attach the transfer coping, open tray transfer coping, it does look like this in the model. Okay. So now the second technique is multi-unit abutment closed tray impression technique. So the procedure is the same. Instead of the open tray transfer coping, you will be placing a closed tray transfer coping and then taking the impression like how you took the open tray. Instead of the any modification in the impression tray is not done. Okay. So you will be manually removing the impression copings, manually removing the transfer copings and placing it inside the impression. So this involves a lot of error, manual error. Okay. So once your impression is sent to the lab, they will be fabricating a verification jig. Why do we need a verification jig? Because we are involving multiple implants. Okay, multiple implants with different angulations. There may be impression material error at the stage of impression material, or your transfer coping might have moved. A slight microns of movement will also give a lot of impact onto your final prosthesis. Okay, so the lab will fabricate a verification jig for you to confirm whether your implant placement impression taking is correct or not, accurate or not. Okay, so a floss is tied on to the open tray transfer coping at the figure of 8 method, and then on top of it a pattern resin is applied. And then the verification jig is sent to you like this. Okay, you all can see, right? The verification jig is sent to you like this, and then you have to check the verification jig with the help of a Sheffield test. The most distal part of the screws are fastened, and make sure the other implant areas are not moving. The other jig areas are not moving. That is the Sheffield test. So what happens if it is not accurate? If it is not accurate, you have to section the verification jig, the pattern resin. Section the pattern resin, and then on top of it you can place the pattern resin again, pick it up and then give it to the lab back. Okay. What happens in lab? The lab person will remove the transfer coping on that area, seat the verification jig onto the model and then pour it again. He will pour it again. Okay. So your new recording is transferred exactly to the lab. So what happens? The next one is, they will, once the verification jig is confirmed, they will fabricate a metal framework. So this is how a metal framework looks like. Okay. So how do you correct? Suppose there is a correction in the metal framework, how do you correct it? Exactly like how you did for the verification jig. You have to section the metal framework and then you have to place a pattern resin, pick it up and then send it to the lab. They will exactly change in the model also. So the next one is, after the impression is made and the verification jig is confirmed, what you have to do is they will give a bite record also. Bite record also will be given. At the simultaneously you are going to take the bite also. Okay. And then this is how your implant hybrid prosthesis is fabricated. Okay. So this is how the prosthetic part of the fabrication of the hybrid denture looks like. So once the wax try-in is done and then verified inside the patient's mouth, in the third picture you can see a putty index of the wax trial is taken. Okay, putty index is taken. Once dewaxing is done, the teeth will be on the putty index, and then there will be veneering, there will be space for the veneering material, acrylic, to flow on the lower side. As you all can see, right, between the implant and the teeth there is gap, right? There will be acrylic flowing onto the prosthesis. Okay. So once this metal trial is fabricated, this veneering material will be, acrylic will be flowing, how you do like dewaxing and fabrication of a denture. Okay, this is how it looks like. And then once the final hybrid prosthesis is ready, you will have to seat and try to make sure that the prosthesis is passive inside the patient's mouth. Okay, and then on top of it you are going to give a ceramic material and then close the access holes. So what about failures? How will you face a failure? Okay, once in a Monday morning you enter into your clinics and then you see a implant patient coming onto your clinic, you should not panic like this. Okay, so how will you face the failure? Failures, It does not mean after you give the prosthesis the statement of failure happens. It does start when you do the treatment planning itself. Okay. So as I had told you, if the patient has only 10 to 12 mm of inter-ridge distance, you should not give a RP5 or RP4 prosthesis. Okay. Right from your treatment plan step itself, your failure is determined. Okay. So once you stick on to your proper treatment plan and then ideal treatment options, your margin of error will be reduced. Okay. So this is what, if you want to see a lot of implant prosthesis, you can always follow Luke Kang. He's an excellent technician. He's working in USA. He a lot of educational posts he posts in Instagram. You can always follow him. Okay. Thank you. If any queries, you can contact my mail ID. This is my mail ID. If any queries, you can contact me. Thank you. Hope it was useful.